I'm Dick Moberg, and welcome to our interview series. A lot of interesting people pass through our doors who are doing amazing work in brain monitoring. We bring them into our studio, put a mic on them, and get the personal stories you don't normally hear. We hope you enjoy them. Hi, I'm Dick Moberg, and I'm here with Debbie Kantor, who went to Penn in nursing school, and she graduated as a nurse practitioner and then worked there for many years. But I think her story is that she became an entrepreneur, which is pretty cool from a nursing background, because she experienced the problems that she's going to tell you how she's solving them, and that's really the basis of a good company. when your founder really understands and experiences the problems that you're trying to solve. So I met Debbie about a year ago at a military meeting, and we just started talking, and I loved her story and invited her here to the company, and we've spent some time together, some good time in the bar last night where we made an amazing connection.
We did.
So welcome.
Thank you. I am happy to be here.
Good. So I would like you to start by telling us your story from Penn and how you got into this, how you became an entrepreneur, and then we're going to talk about your product, which you have here, and we can talk about that. Cool.
Thank you. I've had a very roundabout story that goes on over 20 years as a nurse practitioner. At the beginning, I started at Penn as an undergrad, thinking I would go to medical school. After about a semester, I decided, you know what, nurses are the first point of contact when you reach the hospital. I decided to transfer to nursing school. So I attended nursing school, and you really get your foot in the door immediately in clinicals and having patient contact. I decided to stay on for a master's degree at Penn in gerontological nursing, focusing on geriatric patients, primary care. So you would not imagine needing to deal with emergency patients as much. But I did have a passion for, the full gamut of assessment, head to toe physical exam, chronic, being able to evaluate for chronic problems, acute problems. And so because of my background teaching, I decided to experience multiple different settings in healthcare. Mostly home health care and primary care settings. And I guess, the entrepreneurship began back in around 2015 when I was seeing patients in their home, and I had my aha moment. People talk about when an aha moment happens, and I can really say that was my one moment. I was squatting on the floor of a patient's home, and I was tasked with doing a head-to-toe physical exam. And as I was looking at her amputated stump, she asked me if I could change the dressing. Her nurse wasn't going to be back until Friday. And this woman, the patient, was in her 80s with blindness and a wheelchair and an infected wound. And at that moment, I realized that there was no good wound care product to bandage a cap-shaped wound. And so that moment, immediately I thought, wow, why don't they have this type of product? And from that moment on, I couldn't stop thinking about it. I just had the inventor bug. And so anytime I saw a patient after that, if there was ever a cap-shaped injury, a finger, a toe, a head, I thought back to that moment. And so after seeing enough patients with injuries that required dressing changes on cap-shaped wounds, I decided to file the patent paperwork.
That's great. Yeah.
And I should say that I once had a failed attempt to file a patent years before that, which was not medically related. But the point is, I finally realized that you had to do it right if you wanted it to succeed. And so working as a nurse practitioner, I saved up funds to file for the patent paperwork. And in 2018, I received my first patent, a triple layer dressing for head, stump, fingers, toes.
Wow.
And after that, I realized there are a lot of applications. So you might wonder why we connected over neuro, right?
Yeah. You thought I was a stump.
Right.
Thanks.
Sure, or a finger.
A finger, right.
So after receiving the patent and thinking back about other uses for cap-shaped dressing, not just for chronic wounds, I thought, well, what's the most emergent, one of the most emergent injuries you could have, and that would be a head injury in the traumatic setting. It just so happened that years before that, my own child required brain surgery and was discharged early. She wasn't doing so well as soon as she went home. You've heard this story before, but it was very dramatic because it wasn't just about my daughter. It was about a mass casualty incident that happened in Philadelphia, outside Philadelphia, that very same day. And so, being in the emergency room with family members bringing in their children, and I'm bringing in my child, and realizing how overwhelmed the nurses in the hospital were, and hearing that my daughter's neurosurgeon was otherwise engaged in surgery already. And here I am thinking, well, my daughter's not bleeding, but she's very, very ill, taking a turn for the worse. And, I realized, thinking back to that moment, well, what if we integrated sensors into our cap-shaped bandage? Whether or not a child is bleeding, you still have monitors. Put on vital sign monitors onto every child, and you can see at a glance which child needs monitoring, needs the care first. And so that was how we turned from a low-tech bandage company to a high-tech data science company.
Yeah, and I think the beauty of what I've seen in your invention is the simplicity. And it's a bandage, right?
Right.
But it's a smart bandage, and it's very, very interesting. So
thank you.
What happened next?
Yeah. So
how'd you put the smarts in it?
So this past September, we got a patent on the smarts of it. So we received our second patent for sensor integrated bandage that connects with a mobile app. Over the past couple years, I've started to build up a team around me. We brought on a chief medical officer, Dr. Mike Blibus. He's an expert in ultrasonography as point of care technology, and of course has treated many, many head injured patients. And so he's been extremely helpful. We also have a senior advisor who was president of Smith & Nephew Wound Care Company, and also worked with Mike, our medical director, on Sonocytes ultrasound for the military. And so we started building up a team around us, starting to pitch, for funding, trying to raise funds, which has been a struggle. But we did win an early, chunk of funds. Thank you to Johnson & Johnson as part of their Nurses Quickfire Challenge. So that was the first time, that we really received that true validation that we were looking for. So we've been the first company at the Mayo Clinic Life Sciences Incubator. We did that for a year, won the pitch event for Johnson & Johnson. We took our prototype of the head bandage and ran a simulation study at Mayo Clinic where we tested our bandage versus standard of care rolled gauze. And we had neurosurgeons and neurosurgical nurses on a walk-in basis trial our bandage that they had never seen before against standard of care. And we had only one sensor, and we made a mock surgical wound and a pressure sensor, purely just to check that we could obtain a reading under a compressive bandage. So we took that data, published it with the Department of Defense, published it for Mayo Clinic, and then we've had a bit of a snowball effect, gaining some good traction in terms of the direction where we're heading. So since those early publications, I thought, well, what else can we do with data? We don't just want vital signs. Plenty of sensors have vital signs and monitoring. So I thought, well, we have a connected app. Let's see what else we can do. And so we decided that using computer vision, machine learning, we can start getting insights directly from a photo of the face. And then the data from the bandage and the sensors comes in, and we use back-end data to help synthesize that and come out with a patient summary. And so I was able to obtain a data set with over 21 million ambulance patients in 48 states throughout the US, and it's NEMSIS data. So it's all ages, all races, all injury types, and it's really a robust data set. We were able to analyze that using machine learning, thanks to our partner company. My neighbor is CEO of NLP Logics. I sent my son to work for him as an intern, so got some free scrappy labor and wonderful partnership. They're
That's
one
the
of
way you start. That's
yeah.
Great. Yeah.
So NLP Logics is one of the fastest growing data science companies. Ted Willich was 10 years ahead of the curve, understanding that machine learning would be the wave of the future for data in healthcare.
Mm-hmm.
And so we've analyzed significant data looking at vital signs, Glasgow Coma scale for injury, and most recently looking at whether a patient would report high pain or low pain after a head injury.
Oh, now, how did you get access to that data set? Do you have some magical connections? Or?
Very magical
That was
connections.
another neighbor, right? No.
Yeah. It's called
I'm
Mr.
impressed
Google.
at the way you've done this.
Yeah, Mr. Google. I knew what I wanted to find, and I did find a university that was able to issue me a license to use it.
Wow.
Yeah.
Very nice.
Yeah.
Wow.
Now I'm not using it for commercial purposes, but it's helping establish our direction and how exactly we need to analyze data.
Oh, that's very cool.
Yeah.
Yeah. So now let's get more into the head injury, because that's clearly my interest in that. And
I forgot.
how can you forget that?
I forgot. Yeah.
You're at our intergalactic headquarters here,
yes.
right?
Yes. Headquarters, being the operative. Yeah.
Yeah. So so let's move into that and maybe go through a typical scenario of how we use it and what kind of data are you collecting to inform the emergency physicians on triage or.
Yeah, so we're just figuring out, the whole chicken or egg with our products, since we have multiple products in the pipeline that will become a platform solution. So with that, we're trying to decide where we want to introduce it first. Bandage for ambulance, sensors for ambulance. Do we wait until we have the full solution? We're going after emergency room first for where we would introduce it. So we're in no way trying to replace, certain standard of care. We're not replacing a CAT scan. We're not replacing multimodal monitoring that takes place in neurocritical care ICU. What we are trying to do is use the data that we can collect through continuous vital sign monitoring and other data inputs to help the physician make a better informed decision when he or she makes the decision of whether to refer for neurosurgical consultation, whether to refer for the CAT scan, whether to have the patient sit and wait in observation or just send them home. So,
and this is all pre-hospital, is that right?
Or emergency room.
Emergency room. Okay, got it.
To not confuse, what can be done ambulance. So the problem is that ambulance is a hurry up and wait scenario. So, a bystander calls 911, somebody fell, hit their head, they're bleeding. Ambulance is, very good in most places in arriving. 8 to 9 minutes is what they say on average. They'll be on the scene maybe 14 to 16 minutes with a bleeding head wound. Probably a third of that time is trying to control the bleeding. And then they'll rush them to the hospital, depending on how severe, whether they activate trauma and go to a level 1 trauma center or not. They'll radio in and say, I have a 74-year-old patient, XYZ, Glasgow Coma scale of 14, and see where they take them. And then the ER physician is tasked with making the decision. And then ultimately, if they're severe enough, they would end up with your type of monitoring devices. In the emergency room, there's literature to show that on average, a patient with a head injury will spend 6.6 hours in the emergency room. I think that was research done for BrainScope, actually. Yeah.
That makes sense, yeah.
So 6.6 hours in the emergency room, and I looked at all the breakdown of all the minutes of what's spent where, waiting for transport to CAT scan, and about 60% or more of the time is spent unattended, just waiting. So nurse comes in one time, doctor comes in another time, nurse comes in again, wait for transport, all these different touch points, and patients are sitting there unmonitored. And so it's during that time that you don't really know what the situation is. I know from my own child who was in, the emergency room, it seems like, okay, the nurse comes in and they look fine, but 5 minutes ago they weren't fine. So what was happening? Did they have a drop in blood pressure? Or did they, have some pain from some other process going on? We don't know. And so the CT scan can only capture so much information. The data flow from EMS only provides so much information. And so when the physician needs to make the decisions, it's based on, they do look at vital signs, but a snapshot of vital signs. They look at CAT scan, which is also not a dynamic process. You see what happens then and there. And so with limited information, we don't really know the risk profile. So our goal is to use machine learning to help make certain predictions and not just say they're stable right now, but to say, given this history, their age, their severity of pain, their fluctuations in heart rate and blood pressure, based on these 152,000 head injured patients that we filtered down from a massive data set, this patient is likely to take a turn for the worse. Their blood pressure is 110/70, but it was in the 130s before. Their heart rate is rising. They're likely to take a dip. Watch them closer. So that's sort of our process. We want to create a more dynamic picture of patients during their waiting. It could also be a tool for after neurosurgical intervention for those patients who are more mild and don't require invasive monitoring.
Yeah. So if you're getting all these vital signs, there's probably more applications than just following head injury. I mean, are you thinking of that, or do you want to be the platform, or where's that line between what do you need for a head injury? But hey, a lot of this is also useful, and you don't want two systems collecting the same information, right? So, where's that line?
That's a good question. So I am talking to potential strategics who are interested in our sensors for any patient in the emergency room, not just a head injured patient, because that's really the commonality with all people. We all have, a beating heart, hopefully, and a functional brain. If our heart beats well enough, our brain will function. And so having those vital signs can help for decision making for any condition, whether it's somebody in for anxiety and their heart rate is rising, or somebody coming in with shock, or an infection with sepsis. And so vital signs are what we need for all patients. That's why as nurses, that's what we learn. That's the first thing you do. You go in, you take vital signs. But right now, the way vital signs are checked, the triage nurse in the emergency room, it's typically, one male or female nurse sitting in a cubicle, waiting for the patient to come up, ask some questions, check their vital signs, get their insurance card, all of that. And then they sit and wait. And then they go and wait. And it's a whole process of waiting. So if we could have, something not just for head injury, eventually, that's my big vision. But again, I have to focus proof of concept for traumatic brain injury. And the reason why I think that's an important starting point is because there's so much that's still not understood. Cardiology, we know there's a big focus on atrial fibrillation, heart attack, cardiac arrest, CHF. We're understanding medication for these different conditions and what to do in the emergency room. TBI is so much less understood, and so there's a reason why 40% of TBI patients are under triaged. They're not sent to that next level of care that they should get to. And so you just, especially among older adults, you just have people falling through the cracks. They appear to be fine. They get sent home, and that's when people can, pass away in their sleep, and they didn't have a chance to recover.
Yeah. I think that's what stymied a lot of work in TBI, is just the unknown and the fact that we don't even know what we don't know with TBI. I think some of the big trials, track TBI and center TBI, were these big observational studies where they finally could just look, kind of define what the disease is, not so much the pathophysiology. I think a lot of that's still unknown.
Right.
But they learned a lot from that, and they at least defined some endpoints now that you can do a study and you don't just have a Glasgow outcome score, which is pretty poor. So I think we're at the beginning of really learning a whole lot more about the brain, and the fact that, but it's all going to come down to sensors, and then what you do with that sensor data may change over time as we learn things. So I think the approach you're taking makes sense. It's more a platform, a general purpose one. Right. But the sensors, I think, are the key, and getting those to work well in a bandage, I think, would be a challenge. But from what I've seen, you're making a lot of progress.
We're making progress. It's definitely a struggle. There's I'll say a glut of sensor technology out there. There's so many, we do have competitors in that space. I don't necessarily consider them competition per se, because they're not being used in the same way. And a lot of them, in terms of FDA regulations, they'll specifically say not for critical care, not for over this age, under that age. And I think by creating our platform where we have software and hardware, I'm hoping that we're able to create a solution that could be helpful for people of any age. It might not help in the same way for people of certain ages or injuries, but at least it fills in some of the gaps. And I think some of that is missing. You can't track a patient just based on numbers or no offense, squiggles. That's all squiggles to me. I don't read EEG, so at some point, I'd love to integrate EEGs. That's not my expertise, and even as a nurse practitioner, I recognize that not everybody can be an expert in each piece of the puzzle. And at the end of the day, having this platform is communication, and it's being able to communicate the early story for the specialists who take care of the more severe story. And I think that would give all the neurocritical care neurologists, neurosurgeons, context for the patient they're dealing with now. What did they look like before? Have they gotten better since then? Are they worse? And what else can we glean from these other pieces together?
Yeah, oh, that's great. So can we see the product?
Sure, absolutely. All right, so I have the Bandage and just a prototype of the sensor here.
Cool.
Oh, hold on, start over.
Remember, this is an emergency situation.
It's an emergency situation, right? We're still ironing out the packaging and how it's going to come.
So not in Ziploc bags? Or?
Not going to be in a Ziploc bag. It's going to be an easy tear pouch with instructions so you know exactly how to put it on. That's one of the things.
Can I try it on?
Sure.
Good. All right, let's do it.
Here we go.
Good.
All right. Try it on you. If you were lying down, I'd be able to put it on you without having to adjust as much. And it's
well, that's easy. Look at that.
Yeah, it's easy, and depending on how tight you want to make it.
Nice. Cool. Yeah.
There you go.
Nice. Let me see how. Look at that.
Well, look at that. We're adjusting the chin strap actually, so it will come all the way up.
That's nice. Yeah, it looked like a stump.
Yeah, there you go. Yeah.
No, that's cool. I was thinking, the great Burning Man. Yeah.
I will.
To send me one.
I will send you a few.
Cool.
There you go. Cool. Might even come along next time.
There you go.
What do you know? Yeah, I'm a good cook over the fire. Yeah, that's amazing.
Cool, that's good. So, tell me more. And so this is absorbent. So this would be for an injury, and then the monitors would go in there, right? And
so
you have a prototype of that.
Right now, we have a single prototype. This actually was prototyped by my son, an aerospace engineering student.
Obviously very bright.
He's doing very well, yeah. And we have students at University of Massachusetts now working on a senior capstone project for us to integrate more than just a heart rate sensor.
Right.
So right now we have just the heart rate in here. And I don't know.
This would be flatter, this would be miniaturized.
Yeah,
right?
it'll be miniaturized. It probably will not even have an LCD screen. This is more for demo purposes.
Yeah, yeah.
But what we do have, and you could see, is as the heart rate is normal in our thresholds we gave it, it's green on the LCD. Right now it's saying it's not normal because of course it's not on. So 43 would be a low heart rate, so it's in red. And as it rises to a normal one, it would be green, and there's a yellow threshold, a warning as well.
So it's really the colors that are.
It's the color red, yellow, green, and it's how it's the code tells it to respond based on the input from the patient.
Yeah.
So of course it gets more complex as we include more vital signs. This one's only heart rate, but as we include temperature, oxygen, and look at different trends, we're looking at blood pressure trends, and ultimately ICP, intracranial pressure trends. So
that would go there. Cool.
Yeah, so we're not quite decided yet how it will go. It will probably be more like a cuff link where the actual sensor is going to be underneath and then the light will be through. So this is purely just demo to show that at a glance, you'd want to just be able to glance at a patient and know at a snapshot, red, yellow, green. We've got 10 people from a blast injury, put them on each patient, and you can see, okay, those are okay, stable. Same way you would scan visually, you know, a medic would say, okay, those are moving around. They're more likely better than that one who's not moving. But it's giving that additional ability to scan by having a vital sign monitor.
Yeah.
So
that's cool.
Yes.
I love it.
Thank you.
I love it.
That's not bad, not bad. We could tighten it up a bit. That's the one that still has a bit of a cone head, so it's not you.
So this is good. I'm gonna take this up. So let's just in the last few minutes, let's talk about where you are with the company. So you're raising money. You've made the rounds. I see you've won some awards, and congratulations.
Thank
on
you.
some of these.
Thank you.
And so, where are you now? What are you trying to do?
Right now, we're still raising our seed round, which is a convertible note round. We're trying to raise $1.4 million for the purpose of launching the Bandage and continuing the R&D for the sensor technology.
Perfect, yeah.
We plan to go immediately into a Series A. We have some interest from a strategic potentially for Series A funding, but we're still working out some details, but really we will use the next level of funding for, clinical trial and continued development. So, we have multiple patents, we have an advisory team, we have a medical director, we really just, we have potential distribution channels, places, academic settings, and hospital systems to start testing it. But the funding, of course, like with any startup, is holding us back.
It's the bane of every startup's existence. And one of my VCs many years ago said, "Cash is like blood. If you don't have it, you're dead." So the phase you're in now, I've been in many times. You just take that little bit of money you have and you just squeeze it and make it last. So
which we've been, we've had to obviously pivot on certain projects when there isn't funding here. We figure, well, we can actually make an impact by working on this project there. And we've also realized that while cash is blood or cash is king, it's not equal from one partner to another. I mean, we are, I'll say, somewhat choosy because we want money to come from a strategic partner who can help us with other, work that we have to do, whether it's introductions to hospital systems, helping us with the next stage of funding. I'm really hopeful that, when we get more funding, we can have that. I mean, fortunately, we've received a small amount from Boston Harbor Angels, and with that comes expertise. The investor is actually a regulatory expert, so that's super helpful for us. So anywhere where we're able to, pick people's brains, no pun intended. We're trying to learn from everybody.
Yeah. You've done a lot with a little, which is what investors like to see. So that's.
Thank you. Yeah, and I will continue to keep working at it. It's we all know somebody who suffered from a head injury of some sort. Mm-hmm. Our own team members, multiple team members have had very close instances. In fact, of loss from head injury, and or taking care of members, and so it's very important for all of us emotionally, but also as clinicians and medical device experts. So yeah.
That's good. Well, thanks for bringing us up to date on your product. I look forward to interviewing you in another year or two.
Yeah, absolutely.
See where you are.
Yeah, but until then, I'm sure we will have fun at some conferences, and
I'm sure I'll see you at all the upcoming ones.
Cool, very soon. That'll be exciting.
And you picked a great day to come to Philly. It's the first warm day after winter, and I think we need a drink out on the sidewalk somewhere.
Yeah, and yes, I'm taking you out for a drink. So
cool.
There we go.
Excellent.
All right.
Good.
Thank you.
Thank you so much for
joining.
All right.
Lots of fun.
Bye.
I appreciate
Thanks.
it.